Thank you, Dr. Zhao. And now I would like to introduce Dr. Patty Garcia. She is a professor at the School of Public Health at Cayetano Heredia University in Peru, and she's also a member of the National Academy of Medicine. Dr. Garcia served as our committee vice chair for the report titled Public Health Lessons for Non-Vaccine Influenza Interventions, Looking Past COVID-19. She'll be our primary presenter for today, and I'll turn it over to you, Dr. Garcia. Thanks for being with us.
Thank you, Stephanie. So next slide, please. First of all, I would like to thank you, all the members of this committee that work very hard during this time to put together this report. And also, I would like to thank the National Academy staff that you can see there in the PowerPoint. Next one, please. So our statement of task was to review and come out with recommendations related to public health lessons for non-vaccine influenza interventions based on what we have seen in COVID-19. Which means that there were so many things that we had to review, and it was really challenging. Next one, please. So, first of all, we had to analyze the evidence of the effectiveness of these key non-vaccine measures. And we're talking about masks, indoor air quality, and ventilation that had been developed across different disciplines, and include also novel or existing diagnostic tools that could be adapted and optimized to mitigate respiratory infections. The second thing that we had as part of our tasks was to explore the social and political context that could underlie the effective implementation and optimization of those public health measures and diagnostics. So one is effectiveness, and the other one is how could we implement it in the right way, taking into account the contextual factors. Next slide, please. Number 3 was to review promising COVID therapeutic approaches like antiviral, monoclonal antibodies, host-directed responses, plus the supplies that are needed also for these therapeutic approaches to be implemented, and try to see which ones have demonstrated some effectiveness and could give us some critical opportunities to be used during seasonal or pandemic influenza. And number 4 was to highlight innovations around the world during COVID, as well as other seasonal and pandemic influenza events, particularly that were related to surveillance and rapid, transparent data sharing that can lead to best practices recommendations for notification, contact tracing, testing efforts, and that could include and should include the digital technology and data science. Next slide, please. Finally, the number 5 was to analyze some prominent research agendas, the existing research initiatives, and the knowledge gaps that were identified from the response of COVID and other outbreaks to outline some priority actions for future research efforts related to seasonal and pandemic influenza. So we have these 5 tasks. Next one, please. And actually, we decided to organize these 5 tasks into these 5 chapters. But so you can follow me better when I present it. Chapter 2, basically, because we thought that this could make more sense, was going to be related to these best practices and innovation in surveillance and data sharing. So the first chapter had to do with surveillance and data sharing. Chapter 2. Chapter 3 goes into effectiveness of these key non-vaccine measures. Chapter 4 had to do with the implementation and the social and political context. Chapter 5, therapeutics. And finally, in Chapter 6, we had some concluding thoughts that include several of the different things that had been taught. And in these different chapters, we were including also some priority actions for future research efforts. So next slide, and let's start talking about each of these. So given the study timeline and the scope of the committee's charge, the committee largely chose not to focus on workforce training or capacity, interventions for healthcare workers, as opposed to general population, which most of the recommendations had to do with, and with vaccine hesitancy. So these are the areas that we decided not to include in this report. Next one, please. So the report recommendations, next one. So Chapter 2 had to do with surveillance and data sharing. The first recommendation, 2.1, had to do with the institutions like WHO, the World Bank, National Centers for Disease Control should all work collaboratively with countries, particularly those with a high degree of animal-human interfaces, to build sustainable, and we would like to highlight this word, sustainable capacity for routine surveillance in animals. And this includes wildlife, livestock, and domestics, and develop and support interagency One Health platforms. Next one, please. And this graphic that is part of the report is trying to highlight this multi-scale and multi-step process of pandemic emergencies. So we have tried within the recommendations to direct some recommendations to this pre-emergence stage, which means we need to have good surveillance at this first level to catch things early, but also to keep moving into what to do when we start having the peaks or the outbreaks, and finally what to do when we have the global emergence. Next one, please. So recommendation number 2 had to do with the incentives that need to be built into systems for more rapid reporting of surveillance data from all countries to WHO and to the One Health tripartite, to more quickly be able to identify in that, at the bottom of that figure that I just showed, which one's the origin and the spread of novel agents and strains. And these incentives and barriers to reporting should be removed. So this is a critical issue. We need to have a more rapid reporting surveillance data system from all countries. Next one, please. So recommendation 2.3, countries should institute surveillance as the backbone of their health care systems. So that's why this recommendation goes to national authorities with the advice and assistance of regional and global public health agencies, who should establish these robust surveillance systems that will give true, timely, and comprehensive risk assessment that will help to inform policy decisions. Our recommendation also, it's directed to epidemiologists that should be alerted to potential ascertainment biases. For such biases during the analysis and the interpretation of the data that could happen, so they could be able to alert authorities and take into account those biases and improve the surveillance methods to achieve better representativeness and sufficient geographical coverage. Next one, please. Recommendation 2.4, WHO, the regional disease control agencies, European Center for Control, Africa Center for Disease Control, for example, should work with countries, and national governments should be working also with subnational entities to harmonize, coordinate, and optimize surveillance activities, data collection, and sharing. Next one, please. So from surveillance and data sharing, we're going into effectiveness of key non-vaccine measures. And the recommendation 3.1 had to do with the World Health Assembly. And we discussed that it should be a change in the international health regulations to allow countries to use border measures during a pandemic of influenza or other respiratory viruses. Recommendation, next one, please. Recommendation 3.2, at the global state and local public health agencies and other entities should mandate wearing face masks that comply with WHO's guidance. There is enough evidence, and it's all in the report, that really points into the importance and the effectiveness of the use of face masks. And in the case of influenza, we added that when justified by the incidence and the severity of influenza. Next one, please. Recommendation 3.3. In collaboration with other expert bodies, WHO should develop and disseminate technical recommendations on how to create ventilatory conditions in various settings that will reduce the transmission of respiratory viruses, and should promote this widely and assist countries in implementing them. And we think this is a critical issue. Ventilation needs to be taken into account as one of our weapons to fight transmission of respiratory viruses. Next one, please. Recommendation number 4, the WHO, CDC, as well as regional, national, subnational public health authorities should recommend against the use of plexiglass barriers or the use of face shields without face masks. Next one, please. Recommendation 3.5, and this has to do with research. Okay. What we have seen is that there is research done in the medical fields and research that is more in the area of the scientists. And what we are calling here is that there needs to be an incentive for more integration of the research among these two groups, scientists, medical fields, to inform investigations on transmission, prevention, and treatment of influenza and other respiratory viruses. Such integration should include standardizing and sharing language across sectors and mechanisms in order to share relevant data. Next one, please. Now we go to the other component that we have realized that is quite important. It's not only to know that something is effective, but how can we make it effective in real life? How can we implement it well? And for that, the context is critical. And we have realized that social and political contexts are quite important. So in recommendation 4.1, we're calling for global and regional public health agencies and national governments, including their local and state health agencies, to adopt policies that are tailored to each affected population, taking into account its social, economic, and cultural characteristics, their needs, their resources, and other contextual factors, including its norms, values, and beliefs, in order to optimize the implementation of public health interventions, especially those interventions that rely upon individual behaviors. Next one, please. In recommendation number 4.2, governments, leaders, and departments of health at local, state, and national levels, as well as elected and appointed government leaders, should take the systemic factors, including race and socioeconomic characteristics that affect the health of affected populations, into consideration when developing and implementing public health interventions. Demonstrate in their behavior adherence to non-vaccine measures to prevent influenza in order to promote public trust and uptake of these measures, which means that the governments and the leaders should be showing that they also believe and they adhere to these measures so people will follow. There is a need also to engage the community in the decision-making, and we have to be careful in their choice of words, utilizing more positive communication. And this is something that has been seen during the pandemic. Instead of physical distancing and social solidarity, let's talk about, instead of physical distance, use physical distance instead of social distancing, and instead of individual isolation, we can use social solidarity. So we have words matter, and we need to be sure that we are using the right words. Next one, please. And recommendation 4.3, funding agencies should create mechanisms to support the rapid application of data and implementation frameworks during an influenza pandemic, as well as to enhance these similar mechanisms during the inter-epidemic periods. We need to invest on understanding how to better implement measures that in control conditions work. Such mechanisms can be used to support implementation research on non-vaccine control measures for influenza. Next one, please. National governments, as well as local, state, and global public health agencies, should develop readily and demonstrably implementable intervention plans for outbreaks of influenza and other respiratory diseases. And we want to highlight implementable intervention plans. That's why these plans include embedding the iterative collection and use of data in all interventions, taking into consideration the needs of the population affected, again, with a special attention to needs of marginalized groups. That means that we have to incorporate within the research not only numbers, but also behavioral and social sciences. And these, from the beginning of the pandemic, planners should use proven scientific frameworks in order to guide and improve the implementation of non-vaccine influenza control measures. Next one, please. Now we go to our chapter 5, which had to do with therapeutics. Recommendation 5.1 calls for national governments that should mandate that the appropriate authorities, ministers of health or comparable governmental agencies, should conduct periodic inventory evaluations of existing stockpiles on both therapeutics, including antivirals and supportive care treatments like oxygen, and anything that is needed for delivery. For example, the personal protection equipment. And also, it's not only to create the stockpiles, but also assess what they have the availability to produce versus what they would need to procure, and secure an adequate, reliable supply chain in order to appropriately respond to an outbreak of pandemic influenza. This is a critical issue that we have seen, especially in low middle income countries, which we were not used to stockpiles, we were not able to produce, okay? So we have really to have these periodic inventory evaluations. Next one, please. Recommendation 5.2, the government agencies responsible for public health guidance in each country should develop a framework to guide use and how to prioritize treatments that can be flexible with changing evidence during a respiratory viral pandemic. And again, let's highlight flexible, let's highlight evidence. And changing, because this is an ongoing situation. This framework should be able to be adjusted depending on the pathogen, taking into account its transmission mode, the at-risk populations, and associated morbidity and mortality rates. Next one, please. In recommendation 5.2, this was a little long, there were some important considerations that we wanted to highlight, okay? So WHO will evaluate guidance from global and national health organizations and from professional societies in order to define evidence-based treatment guidelines. Who will evaluate this guidance? How guidelines for treatment selection and delivery will be communicated with the states, provinces, and regions in the country? How suitable are places to administer the care that will be selected? Which population should be the focus of the therapeutic, and how to distribute the treatment modality equitable throughout the country and among patients? Next one, please. In recommendation 5.3, global and regional health organizations should collaborate to determine how therapeutics and the resources needed for their delivery can be shared between countries to ensure equitable distribution and control pandemic spread. Next one. In recommendation 5.4, governments and private companies should focus their efforts on research strategies and platforms that were shown to be particularly effective during COVID pandemic. So those platforms that could allow to screening potential antiviral drugs for safety and efficacy, evaluating therapeutic approaches that target host responses in addition to the viruses themselves, developing and maintaining national and international research collaborations like the ones we have seen with the Solidarity Trial from WHO, and building the capacity for rapid, adaptive therapeutic evaluations during pandemics to inform evidence-based treatment guidelines. We have learned that this type of multinational, collaborative, adaptive therapeutic trials could be really helpful, and we should continue using it. Next one, please. And with that, I hope I want to thank you again to all the members of the committee that will accompany us in this section of questions and answers. And I would also like to acknowledge the chair of the committee, Dr. Alex Capron, and all the staff that help us with this work from the National Academy of Medicine. Thank you so much.